I had a question from a doctor the other day, and he was asking me how I got to the $1 million mark. He was hovering around the $70,000 per month in collections. In some months I do 80, most I do 90, or sometimes even 100. When he saw it, it was 120 that month. And so I wanted to take a little moment and explain how it is I get to this, and maybe some obvious things I haven't mentioned before about getting your practice past the $1 million mark. I think the first thing I have to explain is most of my practice is based on optimization of my current patient load. And I want to explain the difference, because if you don't have a increased demand and a big patient load, like none of the other stuff that I'm going to talk about is possible. So what does that mean? So my typical day, most days, Monday through Friday, I start at 8 in the morning, and the last patient in the morning is at 11:30. So I finish about noon, and then I start up again at about 1. And then my last patient of the day is at 4 o'clock. I see 3 patients an hour. Each patient gets 20 minutes. Now, this is for new patients or established patients. The only difference is on my Fridays, where I double book every patient and I have a nail tech seeing other patients. But that doesn't really bring in a ton of revenue. It just really gives me a person that can see some patients and reduce the other days that we have to do routine care, and she can do some carry flexes that take a little bit longer and things like that. So she doesn't bring in a ton of revenue, but she kind of frees me up. So what I mean by having a full schedule or having more demand than you need is that with that high demand schedule, meaning every slot is filled, then you can optimize your schedule for more profitable patients. Until you get to that point, your whole focus is on getting more patients. Okay, so I want to repeat that again. I know it sounds obvious, but for some people, it might not be. Many times we think that we need more profitable patients, where in the beginning you just need patients. You just need more butts in the door in your treatment room. Okay, once you have developed throughput, then you can optimize. So let me explain kind of some scenarios. So let's say you're by yourself and every single one of your slots is filled, then you can optimize. But sometimes we pull a trigger when we get very full, and then we hire another doctor. When you hire that other doctor, unless you instruct your staff to fill your schedule first and then their schedule with the overflow, you're going to shoot yourself in the foot, okay? Because you're going to be taking money out of your pocket, and you can't be optimized, and you're going to be giving it to the associate that might be salaried, okay? And that's a mistake that we've made a couple of times in our practice. So I'm just kind of helping you out. So there are different phases. Sometimes you can be supply constrained, meaning there's too much supply, and then other times there can be a demand restraint where there's too much demand. It's better to be in the demand constrained, in my opinion. It's always better to have more demand, because then you can get optimal pricing. Okay, you can increase your per visit value if there's more demand than you can fill, which means there's more people wanting appointments than you can give them appointments. Okay, so the way we've done that is with we have 4 doctors in our practice. 3 doctors are very full every single day. Okay, and the overflow goes to the newer doctor that's not as filled. That's how we do it. And that's why I've made recently this urgent care page to help kind of fill up his schedule, and it does fill up our schedule a little bit. Okay, so I want to clarify. So once you have more demand than you can treat, then you can move to phase 2. Until you have more demand than you can treat, you are going to see as many patients and see them back as often as allowable and profitable and, feasible. So what do I mean by that? So until you have too much demand, you're going to probably see your paronychias at 2 weeks and at 4 weeks. You're going to see a follow-up maybe, or just 2 weeks. You're going to see your matrixectomies at 2 weeks and 4 weeks. You're going to see your fractures. You can see them every two weeks. You're going to, all these types of things you're going to do because you don't have enough demand. You're going to try to fill with office visits and procedures and things like that. So once your schedule is totally filled and you have more demand, then, and only then, are you going to start to optimize. And this is what that other doctor was asking me. He was asking me, well, how is it that you can get to 80,000 or 120,000 per month in production? So, because once you have the demand there, then you can increase your profit. Now, there's only a few ways. There's only a few big levers that we have legally as podiatrists to get more profit, because I can't charge insurance. I can charge them as much as I want, but they're only going to pay so much, right? So I'm kind of capped with insurance. I can only, see so many patients without reducing the quality of my visits. That's why I cap it at 3, and maybe there's some quick follow-ups for add-ons, okay, which I talk about. And so what are some of the ways that you can then produce more revenue? So let's go into this. This doctor asked me this, and so I want to clarify. So once you have a filled demand schedule, why still aren't you producing the $1 million mark? It's usually because it's low value patients. Okay, and I'm not saying the value of a human being. Okay, all people have value, and I like seeing patients, but you also have a business to run. You have children to feed. And things like that. So low reimbursement patients. So what do we do for low reimbursement patients? We either spread the time out between when we see them, or we don't see them back, or we put them all together so we can make it a little bit more profitable. Those are the ways that we can do it. So give you an example. Most paronychias are fine. I give them nice instructions afterwards, and most I don't need to see back, so I don't see them back. Before I had all the demand, I would see them back, okay, in 2 weeks. Second thing, matrixectomies I used to see at 2 weeks and 4 weeks. Okay, it was a low-level visit. I wanted to reduce that. Now I see them once at 3 weeks. That's rationale. And not that I like the patients. It's just I think one is necessary. I even know some doctors that don't see them back at all. Okay, that's a kind of a doctor preference. So that's another example. The third example, which I think is the most elegant one, that really this isn't mine. I learned this at the AAPPM. Actually, we were doing it at about the same time as the AAPPM. There was a lecture on this. So we had implemented it, and there was another doctor from Chicago that implemented it, and we found the same benefit. And that was to put all of our patients in a block of time to make it more effective for our routine care patients. So all diabetics, all nail care patients, those tend to reimburse a little bit less than other patients. You try to optimize it by doing diabetic foot exams once a year. You can do diabetic shoes if you do that. You can do PadNet and things like that. You can optimize it, but they tend to still glut your schedule, in my opinion, and that's not the type of patient practice we want. And so what we ended up doing is each doctor has a half day. My half day is on Fridays. There's one of my other colleagues does it on Thursday, and another one does it on Tuesday. So we each have these half days where all we see is the routine patients that's being seen by our nail tech. One of them has the nail tech see all the nails, and he does just another patient schedule. Another one does similar thing, and then I do routine, and I have my staff do routine. Mine are all double booked. So it's a busy day. But it's a way that we can make it most beneficial, and then we really say no any other time. So we restrict our access. But what would happen if someone can't see me Friday morning? Well, then they have to see one of the other doctors, or they have to see my nail tech. Oh, but what happens if they want to see you? There's no option. That's just the way that we do it. Okay, so you have a lot of these questions, and if you set up barriers or bumpers, the patients are going to flow into that. And that was the same thing we did initially when we were learning Shockwave. I used to put all my Shockwave at a certain time so I could get practice. Same thing with ultrasound. I did all my ultrasound at the same time so I could get faster at it. So I think there's a benefit to seeing a lot of similar patients on the same days. It just makes things a little bit easier. So I want to kind of clarify that. So number one would be then taking your low-value patients, putting them all in one day, reducing the amount of time that you see them back or not see them back at all. Okay, and I'll give you another example. Let's say patients that you're going to make recommendations and they don't take your recommendations. Okay, so those ones I don't see back, or I see back at a really long interval. because they're not taking my recommendations of what I recommend is best for them. So it's just another way to reduce those. Okay. So number one would be doing that. If I could do it over again, I have a full schedule, I would put all my routine. And that, for a lot of doctors, you might be scared. You'd be like, well, I've been putting those in my schedule all along. What am I going to do with all that extra time? Well, then you're going to go back to you have too much supply, so you have to get busier. Then you have to fill the schedule, try the urgent care page, and then you have to work on building and getting more leads. Okay, that's a whole marketing question beyond the scope of this little podcast here. Okay, so let's go now to the second thing that I do. So the first is to put everyone on the same day and reduce the low value patients. The second thing is to optimize all of the patients that I see. And I want to give you a couple examples of how I optimize. You can optimize durable medical equipment, and then you can optimize different types of procedures. So let's first talk about durable medical equipment. So for durable medical equipment, first of all, you have to offer durable medical equipment, okay? So if you don't, you have to do that. That's a no-brainer. That's going to bring in a lot of revenue. You have to know how to bill it so you get paid, and then you have to optimize it. So the main way I optimize it is every patient that has a fracture gets a cam boot. That's pretty obvious. Every surgical patient gets a cam boot. Every kind of ulcer patient is getting like a cam boot or a surgical shoe. Okay, these are just obvious things. Really bad tendinitis are going to get a boot. But the real, I think, difference that I've learned is that every patient with equinus, which is mostly all of my plantar fasciitis, Achilles tendinitis patients, are getting night splint. And if they have it on both sides, they get bilateral night splints. And that's always covered by insurance. Okay, even bilateral are covered for patients. So instead of wearing it just 3 hours one day, they're going to wear on each side. So that's 6 hours. It's too much time. That's why I give them bilateral. So really optimizing your DME, and you have to have a really good system. So let me explain this. I know this might not seem obvious, but if it is a hassle every time you do DME, you're not going to do it. If it's complex, you're not going to do it. Just like when I talk to patients about doing, or doctors about doing biopsies. If biopsies aren't easy, you're not going to do them. So my process is I hit the little button I have in my treatment room, which calls my assistant. I said, I need 1 cc of lighter with epi. They get that. I numb it up, have my 2 millimeter punch biopsies right in the treatment room. They're sitting in the bottom drawer along with the little containers of the liquid in there. And I do it, and I put the patient's, there's always a post-it note with the patient's name. I put the post-it note there with the location I did it at, and my scribe does everything else in my note. So it takes me literally no time. Nail sample, same thing. Take a little nail sample and send it out. I don't consider a nail sample a biopsy, but I don't want to get off. Of course, it's just a nail sample, but it has to be really simple, really easy. So all DME has to be easy. So I hit my little button, staff comes in, I say they need a cam boot. My staff, many times, they know this. They need a cam boot. They're going to get what I call the Pelto special, so they're going to get night splint, foam rollering, and morning stretch. That's what I do for most patients with equinus. So this is the process that you can optimize your DME. Okay, that's the second thing I would say is optimize your DME. It has to be a real easy process. You have to have enough of the DME so you don't run out. Okay, so that is going to take you up to the kind of the next level in production. Okay, next thing would be learning to optimize your procedures. So what I'm talking about in terms of, so let's talk about imaging and procedures. So imaging would be getting x-rays. So every single patient with foot pain gets x-rays. Every patient with, once again, foot pain gets x-rays. My staff knows that. So what does that mean? Patient with a really bad callus, they're going to get an x-ray because there could be a bony deformity underneath it that they're dealing with. So every patient gets x-rays. So I do a lot of x-rays. For all Achilles and plantar fasciitis, they're getting 2 views of the foot and 2 of the heel. Otherwise, they might be getting 3 of the foot, or they might be getting of the ankle. So a lot of x-rays. Every patient that has other type of soft tissue issues, neuroma, Achilles, plantar fasciitis, things like that, they're all getting, at some time, an ultrasound. Might be the first visit, might be the second visit. So they're all getting an ultrasound. And in my case, ultrasounds are not covered by insurance. So they're paying, and the way I explain it to patients, I say, this is an ultrasound. Insurance usually doesn't cover it unless you have Medicare. It costs $100, and it's as many ultrasounds as I want to get. So that means I can do one today. I can do one in a few months when I see you back, so we can compare views. And I use that as an educational tool. Sometimes I'll do it on both sides. I don't charge them for both sides, but just to explain and show them how one area is damaged and the other isn't. So you have to really optimize every patient, and this is something that highly has to do with your staff in terms of doing the views of the x-rays, knowing when you need DME, and making the consents, if you do consents, really easy. So that's the imaging. So the other thing is doing procedures. I try to optimize for doing procedures in as many patients as I can, and I try to make it as efficient as possible so I can do it most of the time the same day. So for example, patients come in, have an ingrown toenail, I'm going to do an IND that day. Chronic ingrown toenail, I'm going to do a matrixectomy that day. A flexible hammer toe with a kind of a pre-ulcerative or an ulcer, I'm going to do a flexor tenotomy that day. All the procedures, I have them do that same day. The only reason I would stage a procedure is if they have a really bad paronychia, I'm going to do maybe an IND, and then maybe in 3 or 4 weeks, I'm going to do a matrixectomy. Okay, so I'm going to stage, do one, and then do the other. But most of the time, I try to make it as efficient as possible to do all the procedures. I guess the only exception would probably be like an exhaustectomy, where I need a MIS pack. So I'm doing an MIS surgery, shaving down bone. I'm usually scheduling that just because patients don't want to do that the same day. But most of the other procedures I'm doing, fracture care, which isn't really a procedure, but that has to be used when you think there's a fracture or there is a fracture. Doing that has a little bit longer global, but you have to know how to bill that appropriately. And those I only see one time, for the most part, in 4 weeks. And then I don't see them back after that. So that makes it more profitable because you get paid more up front, but then there's less follow-up care. Same thing, I don't really do much ulcer care, so I don't want to go in too much in depth, but you have to have a procedure to make it profitable. So I guess debridement, and then I also have collagen, the Amerix collagen, but I do not do a lot of ulcer care. I tend to refer them once they get too bad over to the wound care center, just not something that I really like a lot. So we talked about imaging, we talked about procedures. One of the procedures that is really big for me is doing Shockwave, just because I really believe it. I do not do that much cortisone. I do it once in a while. If someone, maybe they've had a cortisone for a plantar fascia or for a neuroma or a first MPJ or for gout or something like that. So I do some cortisone, but I don't do a ton of cortisone. A couple of efficiencies that we do in our office, just to make it, once again, more efficient, was we have both anesthetics and cortisones pre-drawn up, and then they're disposed of at the end of every day. So we try not to leave them till the next day, but we do have them pre-drawn up for about the number of patients that we're going to need each day. It just saves us time having the staff or the doctor draw them up. So making it very, very efficient. So kind of getting me the cortisone or the injection, numb them up, and having staff prep everything else. So the procedures such as Shockwave, I tend to try to do that as well the same day. I'll say, hey, we'll see if we can try to fit you in. Sometimes it can be long though, because you're doing x-rays, you're doing an ultrasound, and you might do Shockwave, so it might put you behind a little bit unless you have a very efficient system. Same thing with Swift. You can try to do that the same day. That's a little bit easier. The only challenge with both Shockwave and Swift, in my opinion, are that the machines are kind of room dependent. We don't have them on a swivel trailer where we can move them from room to room. We have them in a treatment room. So if you're in a different treatment room, our office is a little bit small, so it's harder for us. Swift's a little bit easier to move to another treatment room. But those are things that really help me increase the value of my treatments. Now, some people ask me, well, how do you do so much Shockwave? How do you do so much Swift? I guess procedures, a little bit easier to explain. The way I do it is I use my treatment sheets. So if you don't have my treatment sheets, shoot me an email, don@podiatrypracticemastery.com. I'll send you my link to my treatment sheets. Look at the one on wart, look at the one on plantar fascia Achilles, look at those. Basically, it's a sheet that I put on a clipboard, and I go through it with the patients, and I say, this is how I treat these things. And it has the highlights of those treatments, and it makes it very easy, and it makes a very rational decision for them to do those treatments. So it's very easy. I haven't talked about orthotics. Orthotics are something that I'm always planting the seed with patients. It's on my treatment sheet, and I'm always recommending it if it's appropriate for patients, along with shoes, along with UFOs, all these other recommendations. I do not sell UFOs. Probably should. I think it would be a good revenue generator. I do have many other products that I do sell. I haven't really talked about selling products. I think if you do products, you have to have protocols for those products. I think it makes it a lot easier. So, for example, every matrix gets an Amerigel kit. Every plantar fasciitis and Achilles tendon gets a foam roller, a night splint, and a morning stretch. Every patient that has calluses, fissures, IPKs are getting Cara cream with a pummie bar. Every patient that, you go on and on and on and on. So don't have products that you don't have protocols for and treatment sheets for, because it just makes it so much easier. You do the same thing every time. You don't build up product just kind of sitting there. Every nail fungus gets my UV light and shoe spray, and then usually the terbinafine, or some people do the Lunula. I tend to talk patients more out of Lunula than into it, just because I don't have the greatest results. I know some other doctors, they have just fabulous results, and I would love to be there. I think if I could get patients better without doing the oral, that would be great, but I haven't figured that quite out. So if you found a great way, let me know. Okay. So we've kind of talked about a lot of the high points. I haven't really talked much about surgical procedures. I don't do a lot of surgery, and I do it maybe every 2 months, every 3 months, and I do it reluctantly. I have a very good system of younger doctors that I can refer to, and I think they're actually better than me, and it doesn't take me out of the office. The problem with surgery, it tends to take me out of the office. I knew a doctor, I was talking to him, and what he does is he does the first case in the morning, like from 7 to 8, and then he goes in to see his patient. So I think if to make it more efficient, being like the first case at a surgical center would make sense. A full day of surgery, in my experience, I have a harder time producing enough revenue to condone being out of the office, because I think I do much more in the office. So those are some of the ways to make it much more profitable and to get to the $1 million mark. Once you have you have a lot of supply of patients, so then you can kind of whittle down those patients and kind of see the more profitable ones, see them more often, help them more in the treatment. And then there also is the aspect of efficiency. I'm a big efficiency person of buying my time back. There's a good book by that title, Buy Your Time Back. But I buy my time back with my scribe. So he does my notes for me. I sign off on the notes. So it makes me much more efficient, gives me much more face time with the patients. You can do this similarly with protocols or with your own medical assistant. But I think my scribe, by far, he is what helped me go to the next level in terms of my production. So I don't have to spend that much time doing notes, or very minimal. Every 3 or 4 patients, I'll do that. So if you guys found this beneficial, let me know. Shoot me an email, don@podiatrypracticemastery.com. If you want to meet and say, hey, how can I implement these things, shoot me an email. I'd love to help you. I do have a lot of resources on my blog, my website, Podiatry Practice Mastery. On the bottom, there are a couple of things you might like. There is certainly my $1 million blueprint, kind of going through all of these things that I talked about today in more in depth with little videos. There is an audit, so you can kind of see how your practice is doing, and we could meet up to talk. So it goes through kind of all these things I talk about and says, they're kind of hard questions, and you can do that audit there. And you can set up a strategy call with me. I have some availability during my lunch hours where I like to meet with people. I like to help. If I can help you in a half hour, I will. You tell me your problem, I'll do the best I can to help you. And then if you want more help, I'm doing a 6-month challenge that's coming up soon, where we're going to try to do these things that we've kind of talked about and implement these. I think a lot of times it's good to have ideas, but people have a hard time. Me as well. We have a hard time implementing things without accountability because we are, quote unquote, too busy. Okay, we're kind of busy all the time. So, and I guess I want to talk about the last thing about, like, it's not so much getting to the $1 million mark, but it's having a good life on the side. So I do not do any business on nights, on weekends. I'm not reading business on the weekends. I like to free myself completely from those things. So I think another key is you can't be stressed with your practice. It's not enough to produce that amount and have no life. You have to have a life. You have to enjoy yourself. I think that is a key aspect. So profits aren't everything, but I think being busy is just being better, right? You can give better care, and I think I'm better at caring for patients now than I was in the past, and a lot of it is because I've gotten better at treating those conditions, and most of the time it's with giving more resources and educating patients more with my treatment sheets and other types of things to simplify something that would take me 20-30 minutes to explain. I have it in one video that's on my treatment sheet in a QR code, or on a blog that goes to a blog post with a video. So it's just educating our patients and putting it all in places that's much more feasible for them, and they understand the value of the treatments. Okay, once again, hope you guys enjoyed this. I'll talk to you tomorrow.